वालेकुम। आज हम अपना नेक्स्ट टॉपिक स्टार्ट करेंगे। टॉपिक का नाम है द ग्राइन इन दी स्पोर्ट्स। Outline: this chapter will review the functional anatomy of the groin and hip and explain the causative factors of the acute soft tissue injuries of the groin and the hip joint. Second, discuss the differences between acute and chronic injuries of the groin and the hip joint. The chapter will further provide an overview of common soft tissue injuries of the groin and hip by detailing the assessment, management, and rehabilitation strategies and protocols. The groin consists of the structure deep to the anterior and medial intersection of the legs and the lower abdomen and includes the structure of the perineum. Movement of the hip underlies and affect the groin structures. The groin therefore particularly includes the lower rectus abdominis musculature, inguinal region, symphysis pubis, the upper portion of the adductor muscles of the thigh, the genitalia, including the scrotum in males. Groin pain in sports. Groin pain is one of the most poorly understood syndromes in clinical sport medicine, despite its relatively common occurrence. Sports medicine literature discussion. A single pathology presenting in various ways, one of multiple distinct entities that need to be accurately diagnosed and treated differently. Several merging pathologies that coexist, resulting in a similar syndrome that requires almost the same treatment no matter what the presenting symptomatology. Unsatisfactory causal and the diagnostic opinions lie in the complex anatomy of the groin. The groin is a relatively unstable area acting as the link between structures that generate large forces through it. Groin pain can therefore be related to these several different joints, particularly the lumbar spine, SI joint, sacroiliac joint, hip and pubic symphysis, the adductor muscles, hip flexors, gluteal muscles, abdominal and lumbar extensor muscle groups, the obturator, ilioinguinal and genitofemoral neural structures. Functional anatomy. Pelvis is a ring of the bone with symphysis pubis joint anteriorly and two SI joint posteriorly. Gluteal muscles stability, transfer power between legs and trunk. Hip flexors muscles running and kicking. Hip adductor muscles kicking diagonally around the midline. The rectus abdominis internal and the external oblique and transversus abdominis abdominal muscles all combine to perform pelvic movement and contribute towards stability. The quadratus lumborum muscle. The biomechanics around the pelvis is such that dysfunction and imbalance of any one or more of these anatomical structures. Disconnection in the chain of movement, especially in the complex and stressful environment of sport, several related pathologies. ये हमारे पास groin region and its surrounding anatomy, sartorius muscle, femur bone, gracilis muscle, adductor longus, adductor magnus, adductor brevis, pectineus muscle, adductor longus, obturator externus, pubis bone, pectineus, inguinal ligament, capsule of the hip joint, iliofemoral ligament में नजर आ रहा है और rectus femoris muscle. Groin and the surrounding anatomy, inguinal canal, inguinal ligament, दोनों साइड पे external oblique muscles, अम्प्लाइकस हो गया सेंटर में, लीनियर एल्बा ये जो स्ट्रेट लाइन मिड में है, रेक्टस एब्डोमिनल कवर्ड बाय द शीथ, रेक्टस एब्डोमिनस विदाउट शीथ, ये रेक्टस की शीथ हो गई, इलियक क्रेस्ट. Overview of the groin injuries. Groin pain can be difficult to examine and assess for a variety of reasons. The history and location of pain is often ambiguous. Therefore, the history and examination should be approached methodologically. Discussion of the factors that aggravate or reduce pain, especially relating to specific aspects of the athlete sport, is essential. For general guidance only, histories of duration longer than several months or one session are usually hip joint related, whereas less than 3 months can be various pathologies. Histories must include duration, location, onset detail, predisposing factors, response to rest and treatment so far, investigation history like X-rays, ultrasound, MRI, CT scan, and bone scan. Incorporated within the varied clinical tests used, assessment must ideally include inspection for asymmetry and anatomical irregularities, including poor habitual posture, Assessment of the range of motion of the joints near the area and particularly movement of the hip joint and pubic symphysis stress test. Observation for the discrepancy of leg length, जिसे हम LLT भी कहते हैं. Evaluation of gait including if possible the individual's specific sports activities that exacerbate the symptoms and training load. Muscle length and strength test including adductor weakness, abdominal gluteal control and load transfer failure. Palpation of the affected area. DD for the groin injuries, pain that is aggravated with activity and alleviated with the rest suggests a structural problem. Constant pain suggests an infectious, inflammatory, or the neoplastic process. Differential diagnosis must take into consideration medical conditions that affect the groin in all individuals, not just athletes. Referred pain from the lumbar spine pathologies, hip joint disorders like osteoarthritis, Barthes disease, slipped epiphysis, osteochondritis dissecans. Intra-abdominal disorders like appendicitis, genitourinary abnormalities like UTI and STDs. Impact injuries such as those that occur during football, hockey, or other contact sports may result in contusions. However, such injuries may cause fractures of the pelvis, exacerbate previous asymptomatic inguinal hernias, and in rare cases produce bladder, testicular, or even urethral injuries. Any patient with lower abdominal or the pelvic impact injuries that cause severe groin pain, loss of function, or blood in urine should be immediately medically investigated. Hip pointer. The hip pointer can arise from both direct contusions causing impact and indirect strain injuries of the hip, primarily in the contact sports. Forced extension of the hip by, for example, a tackle from behind in rugby may result in a sprain or avulsion fracture of the sartorius muscle at its iliac crest attachment. These injuries are severely painful and make the leg movement very painful, taking from 1 to several weeks to rehabilitate depending on the severity. Pain may be felt when walking, laughing, coughing, or even deep breathing. Direct contusions to the anterior superior iliac crest may also involve the attachment of the sartorius muscle. Treatment and rehabilitation of the pointer hip. Initial routine, ice treatment and compression, and rule out bony injuries or more significant soft tissue damage by X-ray or scan. Medications as required, including the topical anti-inflammatory when the injury is superficial. Immobilization with crutches if necessary during the acute period, which may be days or weeks. Incremental progression to return to sport, including proprioceptive mobility and strengthening. Classic groin strain या फिर pull. The most frequent acute strain of the groin may involve single or multiple muscles, including the iliopsoas, adductors, and the gracilis. Falling, running, changing direction, kicking or doing the splits may generate these injuries. Groin strains usually cause pain in the groin and radiate down the inside of the thigh, more proximal than distal, with pain on resisted adduction of the hip joint. Adductor tendinopathy. The muscle most commonly strained in the groin is the adductor longus. Groin strain usually cause pain in the groin and radiate down the inside of the thigh, more proximal than distal, with pain on the resisted adduction of the hip. Treatment and rehabilitation. Soft tissue release techniques to reduce tightness can be combined with progressive strengthening of the adductor muscles. Injuries to the muscle bellies are best managed with the strengthening, gentle stretching, and progressive return to activity. Avulsion injuries to the tenoperiosteal attachment requires more conservative management with rest until the patient is pain-free, then strengthening and very careful stretching. Injection of corticosteroids around the adductor origin, proximal thigh strapping to dissipating stress away from the weakened area, and adductor tenotomy. Next condition is iliopsoas syndrome. Flexion of the hip, a fundamental sport movement as in running and kicking. In between the proximal iliopsoas tendon and hip joint lies the psoas bursa, which helps to reduce friction. Iliopsoas syndrome is inflammation of iliopsoas bursa and or iliopsoas tendinopathy and is often found in conjunction with adductor abnormalities. Pain in hip and upper thigh as well as stiffness. Treatment and rehabilitation. The condition will often settle down with ice treatment, rest, sport, and initial inflammatory medications. When the acute pain has diminished, a program of progressive flexibility is initiated. Work on core stability. Fifth condition is hernias. The sportsman hernia or the Gilmore's groin syndrome occurs when there is a weakening of the muscles or tendons of the lower abdominal wall. This part of the abdomen is the same region where an inguinal hernias occur called the inguinal canal. When an inguinal hernias occur, there is sufficient weakening of the abdominal wall to allow a pouch the hernia to be felt. In case of sports hernia, the problem is due to weakening in the same abdominal muscles, but there is no palpable hernia. Physical test for the hernia to help determine whether you have sports hernia. Your doctor will likely ask you to do a sit up or flex your trunk against resistance. If you have a sports hernia, these tests will be painful. Non-surgical treatment for the hernias. Rest in the first 7 to 10 days after the injury. Treatment with rest and ice can be helpful. If you have a bulge in the groin, compression or wrap may help relieve painful symptoms. Physical therapy. 2 weeks after your injury, you may begin to do physical therapy exercises to improve strength and flexibility in your abdominal and inner thigh muscles. Anti-inflammatory medications. Your doctor may recommend non-steroidal anti-inflammatory medications to reduce swelling and pain. The successful Gilmore groin rehabilitation program emphasizes the importance of activating the core stability muscles, particularly transversus abdominis with the multifidus. Week 1, first day after operation, essential to stand upright and walk 20 minutes. Thereafter, walk gently 4 times a day. Gentle stretching and core stability exercises given by a physiotherapist. Week 2, jogging and gentle running in straight lines, gentle sit ups with knees bent, adductor exercises, and step ups. Week 3, increase speed to the sprinting, increase sit ups and adductor exercises, cycling, swimming, and crawling. Week 4, sprint, twist and turn, kick, and play. Sixth condition for the groin injuries is nerve entrapment. The nerves that have been involved in the groin pain are obturator, ilioinguinal, and the genitofemoral. The sports person will usually describe a difficulty to localize intermittent, sharp, or burning pain in the medial thigh or the genital area. Due to hypersensitivity of the irritated nerve, pain may be aggravated by a very light touch of the sensitized area. A local anesthetic injection, specifically in the area, can be used as a confirmation of the diagnosis. Treatment, neural and hip stretching movement, surgical release, hydrotherapy, and swimming. Seventh condition, hip dislocation or hip fracture. The most severe and debilitating groin injury is a hip dislocation or the fracture. This usually results from the violent or high-speed impact collision or the fall, seen in sports like skiing or the ice hockey. Visible shortening band with leg rotation medially and laterally can occur. Management, immobilization, and medical investigations with reduction. Hydrotherapy for mobility, progression from non to partial weight bearing, balance, and strengthening exercises. Eighth condition is ligamentum teres tear. In relatively major trauma, this ligament in the hip joint can cause hip instability with catching or clunking symptoms. They can occur in sports such as gymnastics, where there is extreme hip abduction. Arthroscopic surgery is usually necessary, followed by steadily progressive rehabilitation. Fundamental cycle of rehabilitation in these sports: multidirectional impact, sports activity, rehab या फिर sports, weight bearing injury, relative immobilization. फिर यहाँ से स्टार्ट करेंगे वेट बेरिंग इंजरी हुई है, वेट बेरिंग इंजरी के बाद रिलेटिव इमोबिलाइज कर देना है, हाइड्रोथेरेपी देनी है, वेट स्टेबिलिटी करानी है, कंट्रोल लो इम्पैक्ट, मल्टी डायरेक्शनल इम्पैक्ट और फिर स्पोर्ट्स एक्टिविटी की तरफ वापस लेके आना है. Ninth condition is avulsion fracture. Groin pain from the avulsion fracture of the hip must be considered, particularly in young athletes who say they experienced acute, sudden onset specific pain. The relative weakness of apophysis of the adolescent skeleton predisposes the young athletes to a variety of avulsion fracture, two of which are forceful movement, avulsion of the anterior inferior iliac spine by the rectus femoris, the avulsion of anterior superior iliac spine by the sartorius muscle. Management, conservative management, rest, and gradual incremental return to activity. 10th condition is loose bodies in hip joint. These are rare but may be as a result of cartilage pathologies causing catching and locking of the hip. The loose, badly The loose body usually needs to be removed arthroscopically. 11th condition is stress fracture. Femoral neck and the pubic ramus are the most common stress fracture in the groin region. These are caused by repetitive trauma to the bone or through the muscular attachment. Treatment and rehabilitation, modification of the causative stress pattern, rest, usually reduction of weight bearing with the crutches, non-weight bearing progressing to recovery, although usually complete, may take several months. 12th condition is avascular necrosis of the femoral head. This is an insidious condition that usually affects individuals between the ages 20 to 40 years. Disruption of circulatory supply to the femoral head, either acutely or chronically, result in cell ischemia and necrosis, eventually damaging the hip joint. 13th condition is osteitis pubis. The symphysis pubis is a fibrous joint between two halves at the front of the pelvis. High shearing forces, adductor muscles attach either side and abdominal muscles attach along the top of the pubic bones. The shearing forces can be increased by biomechanical limitations such as restriction of the internal hip rotation. There is associated instability at the symphysis, and the athlete may be aware of clicking in the region, often noticed when turning in bed. Diagnosis: X-ray, mottled appearance at the symphysis pubis. MRI show edema in the bone, and bone scan shows increased uptake in the pubic bones. Treatment and rehabilitation of the osteitis pubis. Treatment of this condition is notoriously difficult due to pain will often respond well to inflammatory medications. Treatment of this condition is notoriously difficult. Pain will often respond well to anti-inflammatory medications initially. However, symptoms often gradually or suddenly become more acute with pain that inhibits or stops activity, becoming unresponsive to the conservative management. Strengthening exercises for the core and muscles around the pelvis and the lumbar spine. Injection of corticosteroids are the sclerosants and surgical curettage. Fourth condition is hip labral tear. The labrum is a lip of the cartilage around the edge of the hip acetabulum, which serve to deepen the socket, providing added stability to the joint. In jumping and kicking sports such as high jump and football, there are significant repetitive stress placed on the labrum. Examination may show decreased range of flexion, abduction, and internal rotation at 90-degree hip flexion and positive impingement and the groin test. Patient will complain anterior hip pain with radiation to the anterior thigh, aggravated by sitting and squatting. Treatment and rehabilitation, limited success with tractional mobilization. Hydrotherapy for the hip stability and mobility may diminish symptoms. Treatment in elite level athletes, the arthroscopic surgery has been very successful. Rehabilitation exercises for the groin. There is evidence that physical therapy aiming at the strengthening and coordinating the muscles, stabilizing hip and pelvis has superior result compared with the passive physical therapy. The pelvic mobility control and proprioceptive stability of the athletes are important in preventing injury but are also fundamental towards performance in sports. The performance benefits of the strength and conditioning exercises can be a useful tool of persuasion for the therapist to convince the athlete and coach of the benefits of the certain exercises and drills. थैंक यू फॉर वॉचिंग. नेक्स्ट इंशाल्लाह मिलेंगे किसी और टॉपिक के साथ. तब तक के लिए अल्लाह हाफिज़.